So hello everyone. I would like to welcome everybody to another edition of Heart to Heart Conversations. This will be broadcasted on various platforms, starting with PCR Online, where you can ask comments, over Facebook, LinkedIn, X, and so on. Please join us in the discussion about a topic which we thought is interesting today, and that's renal denervation from guidelines to practice. I'm very glad to have with me today Professor of Cardiology, Andrew Sharp from Dublin University College and Mater Misericordia Hospital in Dublin. Andrew, thank you very much for joining us. You've been one of the pioneers of this field. It's great to have you here.
Thanks, Dejan. It's great to talk about this today.
So first, what I would like to ask you is, what is your practice today? I mean, hypertension treatment now entails renal denervation at some stage. And the question is, if the guidelines now tell us that we can do it and that we should do it in some cases, what is your practice? How does your practice of hypertension treatment today accommodate for the fact that renal denervation is one of the recommended treatments?
Thanks, Dan. Well, it's been a long road. It's been 15 years since I first got involved in this space. And now, as you say, it's guideline recommended. We have a Class 2 recommendation from the European Society of Hypertension and a 2B from the European Society of Cardiology, which we can go into a little bit later on as to why it was 2B. So I have always tried to enroll my patients in clinical trials. So I was involved in many of the clinical trials that have got to this point. And so I was lucky enough to have that facility. But if I'm using this procedure clinically, I do tend to try and stay to the spirit of the guideline recommendations, which are establish resistant hypertension, try and work out whether you can improve drug adherence if there are drug adherence issues, exclude secondary causes, and then use this as an add-on therapy once you've got through step 4 of the pathway. So ACE inhibitor or angiotensin receptor blocker, calcium channel blocker, diuretic, and then a trial of spironolactone. And once you've got through that, I think you've given patients a good go at pharmacology, and then it's reasonable to talk to them about renal denervation. And not everybody wants it. About half of patients, in my experience, will then engage with that and they'll be interested in the therapy, and half just won't like the idea of a procedure. And that's pretty par for the course across the different technologies for something like this.
So before we get into more details about the evidence space for these guidelines, the actual guideline recommendation and the various technologies, the question that I would have for you is, do you perceive this now as an established treatment, which is catheter-based for hypertension, in addition to, of course, medications?
Yeah, I think it is. It's in the guidelines now. And it's not as if we don't have a problem in hypertension. So hypertension is the most important disease in medicine, which always gets me raised eyebrows when I say this from the lectern, but it's true. It is the number one cause of death in the world, the number one cause of death in most European countries, if not all of them. It's the number one cause of heart failure, heart attack, and stroke. 1 in 3 of patients over the age of 65 have this condition. And it is a major healthcare problem, and only around 50% of patients are at control with pharmacology. Now, pharmacology is fantastic. I also run a hypertension clinic as well as being an interventional cardiologist. And so drugs are good. We've got lots of data on them, hundreds of thousands of patients worth of data. But the patients are telling us something when only half of them are at control, despite the fact that if you just gave 3 drugs to all the hypertensive population, you'd have control rates of 80 or 90%. So there are some patients who are intolerant, some patients who just don't like drugs, some patients who don't want to take diuretics, for example. Can you imagine doing a CTO procedure while you're on a diuretic? I mean, it would be the end of...
That's a good question, yeah.
Yeah. So I think drugs are good, but they're not doing it. That's 50% control rates to a standard of 140 over 90. Now, the targets are below 130 over 80, quite rightly, because it looks like a linear reduction or a log linear reduction in events down to a level of around 120 systolic. So 130 is our new target. We will have around 30% of patients at control by current standards, although we haven't yet aimed for that stricter target, so we'll have to see. But it's not likely to go up. I mean, now that we're giving tighter standards of control, I can't perceive that this would go up from 50% control rates that we currently have at that 140 mark. So there's definitely space for innovation in hypertension, and this is one option that is now guideline approved. I think we should be considering this now.
Okay, that's very good. So now, I mean, many in the community would ask the question whether the evidence base is consistent or not.
Yeah.
So when you think about the randomized sham-controlled trials, which per se are high-quality trials, of course, when you think about them in the field of renal denervation, there are those which we could call positive, the green ones, or those that were neutral, or you could even call them negative trials, which you could say are the red ones. So the question is, why do you think that there have been mixed results of randomized sham-controlled trials in this space? The way that I tried to explain to me, at least, how this concept of renal denervation works and how it was proven, is that those trials which compared renal denervation with nothing, so no medication, versus renal denervation, they worked out. So they did consistently showed a lowering in blood pressure. And then other trials which compared renal denervation with one or more medications, antihypertensive, they were mixed. So what's your take on that? What's your take on the evolution of the trials from 2014 until today? And what's your take on the fact that there were mixed results?
Well, Renal denervation now has published 7 positive sham-controlled trials. There is nothing else in device medicine that has that standard of evidence. So it's taken a bit of a beating over the years, partly because some of the headline studies were negative, and I'll tell you about those in a second. But we have 7 positive sham-controlled trials. I mean, we don't have a single positive sham-controlled trial in PCI. Of course, Orbiter was negative. You could argue Orbiter 2, although it was a slightly different design from Orbiter 1. And then in some other conditions, like, for example, tricuspid or mitral interventions, we don't have that. So what happened? Well, basically, sham-controlled trials are hard to do. If you do placebo-controlled trials with drugs, they tend to be very large-scale because it's very cheap to do a trial where you just give somebody a pill. When you're doing device trials, it's harder because there's much more complexity involved in delivering both arms. So the first sham-controlled trial in this space was Simplicity HTN-3, and that sort of brought the field low, and it almost finished the field off. We'd had Simplicity 1, an open-label registry-type study, very strongly positive, big drops in blood pressure, 30 points. Simplicity HTN-2, a randomized trial, it was just that it was open-label. Now, there's a lot of device medicine where it's open-label, and that showed a 32-point reduction in the renal denervation arm and 0 in the control arm, but the control was open label, as was the denervation. Then came HTN-3. So this is over 500 patients. They were randomized to have denervation or not, and it was done in America. This was the first time our American colleagues had been allowed to perform denervation, and it was with the single-point electrode catheter, the radiofrequency catheter. And what happened is the renal denervation arm came down by 14 points, but the sham arm came down by 12 points. And that was assumed at the time that that was a sham effect, and therefore the whole thing was maybe a placebo effect. But we subsequently reanalyzed those data and found that, firstly, with this single-point electrode, it was very difficult to get the required north, south, east, west denervations within the artery. So with that electrode, you had to make sure you did 4 burns at opposite sides of the artery. When you look at the data published in the European Heart Journal by Dave Kanzari, a secondary analysis of that trial, only 6% got bilateral north, south, east, west denervation. So there could have been an underdosing of the delivery of the energy in that trial. The other thing is you weren't supposed to change medicines. So these patients were on 5 medicines, which usually screams non-adherence, to be honest, because if your blood pressure is 170 on 5 medicines, one wonders whether patients are taking all of those, because there aren't that many patients who are resistant to 5 drugs. So we had changes in meds in 40% of the patients between their randomization procedure, so either renal denervation or sham, and then the 6-month primary endpoint. And so what we think happened in that trial is there was a difficulty in delivering adequate dose to both renal arteries, but more importantly, with the long-term data, I think the most important thing is that there was variation in medication adherence, and then changes in medicines by the teams within the trial that led to narrowing together of the arms. So how can I say that? Because the sham effect in the off-med trials of renal denervation in the ambulatory blood pressure arm is between 0 and 2 millimeters of mercury. And in HTN3, it was 12. So we haven't seen those sorts of sham effects again. And that tells us that it wasn't a placebo effect. It was a drug confounding effect. So that's what led to these new trial designs, these off-med trial designs. This is actually how you prove a new drug. If I invent a new hypertension drug and bring it to the FDA or the EMA, they will ask me to take patients with mild to moderate blood pressure off their drugs so that the drugs can't confound the testing. And then you randomize to the new drug or a placebo. And that's what we did. And once we got all these drugs out of the way with their noise and their variation in adherence and the stimulus towards giving extra prescription, we found a very clear signal across multiple studies, multiple technologies, showing that renal denervation worked.
So a question, this was a beautiful description of the evolution of evidence. So the question that remains is, if in off-med trials, which means that the control group did not have any medication, it was proven that renal denervation works. The question is, how much of the effect do we expect? In those trials, if I recall correctly, was around 5 to 8 millimeters mercury. So is this something which we would expect if we add it on top of the drugs, or is the situation there different?
So it is different. So because we had to take patients off meds, and in the sham arm, they were off those medications for 4 months. So we had to adhere to strict ethical guidelines from the FDA and from the ethics committees. So what we had to do was pick mild to moderate hypertension. So starting blood pressures in the Radiance program around 150 and in the Spiral program a little bit higher. But what that means is there's a floor to blood pressure, and we've seen this across many trials of renal denervation, that the higher your starting blood pressure, the bigger the fall. And it's not just as simple as regression to the mean. This appears to be a physiologic effect. It's been shown now in tens of thousands of patients who've underwent this procedure. The higher the starting blood pressure, the bigger the fall. And it makes sense to me that there's a floor to blood pressure. And if as you have milder hypertension, you're going to get a smaller proportionate reduction. So in the clinical trials, the treatment arm got about 10 millimeters of office blood pressure reduction. The control arm was something from 2 to 4 millimeters of mercury. And by convention, we subtract one from the other. But having been involved in these trials, I can tell you that it wasn't a placebo effect in the other side. It was people who were restarted on meds because their blood pressure got too high, patients who deviated from protocol and were taking medicines that were not in accordance with the trial protocol.
Okay,
so the effect size is about 10 for mild to moderate hypertension. In the real world, when we start with more severe hypertension, it's around 15 on average in the Global Simplicity Registry, huge registry of 3,000 patients with the radiofrequency device.
And it can also increase over time. I think this should be mentioned. So we've seen signals for that, or a 3-year follow-up, that this effect of renal denervation could increase over time.
Yeah, it's fascinating. So we thought this might have been a statistical fluke in that perhaps the patients who were coming back at 3 years were the ones who'd had a good response. You know, the ones who came back were grateful. They saw their blood pressure have a big fall. The ones who had no response were like, I'm not coming back and seeing you guys. It's all a bluff. But in fact, we're seeing this across many, many data sets. And it's a fascinating phenomenon. So we're still not sure if it's genuinely real. But we've now got 10-year data showing that the patients are at least at the same level of blood pressure lowering. And some of them are on fewer meds, and some of them have greater blood pressure lowering. So over a 10-year period, we should see a rise in blood pressure, right? As people get older, they get more likely to raise blood pressure. And yet in these cohorts, we're seeing the blood pressure come down and either go down a bit more, or the patients are on fewer drugs at 10 years. So that's an exciting development. We didn't expect that, but we are seeing that.
That's very good. So now I would like you to comment on the actual guidelines. So when you speak with many colleagues, the recognition of renal denervation in the guidelines, and particularly in the European guidelines, did lead to many centers started to think about implementing this program in their practice. So the question is, what do guidelines specifically say? Do we have to use it, or should we use it in patients already on 3 or more medications? Or is it also reasonable to use it in patients with less than 3 medications? And which centers should do it? And how should we convey these messages to the patients?
Yeah. At the moment, the guidelines, the ESC guidelines say consider it, and as does the ESH. It's got a 2B recommendation in the ESC guidance. Now, given that there's 7 positive randomized trials, people might think it's a funny thing to get a class 2B. So what it is if you're on 3 meds, including a diuretic, and then you add renal denervation, which is their clinical recommendation, there's only one trial that did that design, and it was positive. It was Radiance Trio. We gave a triple pill of 3 meds and we added denervation or sham on top, and it lowered blood pressure further, again by around 10 points of office blood pressure. So because it's only one trial, it gets a 2B. But there's other trials with fewer meds and off meds. So although it's a 2B recommendation, I personally think that it should be stronger than that because the concept of denervation is stronger. In terms of whether one must do it, then of course for a device procedure, that's not the case. We've got to discuss it with the patients and see about patient preference. There are some hypertension clinics where you might go to drug 6, 7, 8, 9, but we saw from data from the pharmacology literature decades ago that once you get up to drug number 5, number 6, typically you've got quite significant rates of non-adherence. And so if patients are getting side effects and not taking their pills, or they're psychologically unwilling to take pills, and you've done everything you can to solve that as a physician, then I think it's reasonable then to add on denervation if your patient has uncontrolled blood pressure. That's particularly the case if they've got cardiovascular risk, and the European guidelines have given a slightly stronger recommendation for those in cardiovascular risk in the sense that they don't insist on this 3 drugs and then consider denervation. So I think that makes sense. If we know the time in target range of blood pressure is a determinant of events, and the longer you are uncontrolled, the greater the risk of cardiovascular events. And that makes sense. It's miles on the engine of your car. If your engine of your car has been running hard for many more miles, then it's going to burn out more quickly. So I think what they're saying is don't spend too long going through a drug cascade and leaving patients uncontrolled if you have high cardiovascular risk. And I agree with that. I think that's sensible. The days of seeing patients back and forward for 5 years while trickling in drugs 7, 8, 9, 10, I think that's probably no longer the right way to do it. We should be considering device therapy earlier on. And then if we're still not under control, then we go down those drugs that cause so many side effects.
But that's potentially opening the doors towards a huge number of potential candidates for this therapy, because if you're not going to explore all kinds of medications before even thinking about the catheter-based methods, then you're going to have a lot of patients who you would consider with, of course, high cardiovascular risk. So the question is, and this is also mentioned in the guidelines, how should you start a program? I mean, if the guidelines do say that you should have already some experience with it. We chatted before this a little bit. How can you start a program then? So what's on that? I mean, if you're starting with the program, then of course you're not going to have your experience at the beginning. You will build it up. How important is operators' experience for the results that we've seen, at least in the positive trials?
Well, the technologies differ in the learning curves, but all the learning curves are pretty short. So what Sky recommend is 5 proctored procedures, and if you've got experience in the renals. And I think the most important thing is if one has never been active in the renal arteries before, is just getting used to at least soft touch cannulation of the renals, if not no touch cannulation. So we want to be a little bit gentle with the osteo of renal arteries. And then after that, it's just understanding the anatomy, understanding the way it behaves, understanding what happens in deep respiration, where you might lose contact with a radiofrequency catheter, for example. But the learning curve is pretty short. So I think proctor cases are important. Thankfully, the only advantage of a 15-year development phase of this is that the industry proctors who support the cases are very well trained and extremely experienced, because it's been such a long road. They know everything there is to know about this now. But physician proctors are not such a bad idea if one has never been near the renal arteries before. So I usually say to people, there'll be somebody near you who's doing renal angiograms or renal angioplasty. The numbers have cratered now since Coral and the negative trials of renal angioplasty, but someone somewhere is cannulating renal arteries. Just go to the lab, watch them do it, talk to them about it. It's pretty simple, but as with all things, you see it a couple of times. It's easier when you start doing it yourself. And of course, it's femoral access. So it's 6 French for the radiofrequency device, 7 French for the ultrasound device. Both of those are going to come down and radial options will become available. But femoral access should be, according to the TAVR techniques that we've learned in recent years, of really ultrasound guided fluoro marking of the head, micropuncture access, upsizing, checking with fluoroscopy that we haven't done any harm before we hyperinize. These are simple steps that we have learned in TAVI that are essential to safe access. And in the denervation trials, the rate of growing complications was around 0.1%. It was tiny. So we showed that it could be done safely.
I think that's an important point. We'll come at the end of this session to the technology one more time. Before that, I would just like to briefly touch upon the patient selection, because if we are to build the programs, if this is going to spread to accommodate the needs that you have described, then I think an efficient patient selection program will have to be implemented as well. And there are several challenges to it. If we think about a step-by-step process, then of course ruling out secondary hypertension, especially younger people, is something which should be at the very start. And then, of course, reviewing existing medication and the adherence to the medication, you already said, and being open about it. I think allowing for the patients to express also, of course, their concerns of having many medications and maybe a preference even towards catheter-based methods could be something which could happen in the future. Of course, we have to take into account what you just said, the good safety profile of the technologies that we have. And of course, at the end of the day, the global cardiovascular risk may decide whether we use the technology or not, even in those patients who are not on more than 3 antihypertensive medications. At the end, it will boil down to a question whether the patients will accept it or not. And what's your opinion on that? So 2 questions for you in this regard. First, how is it that you select the patients? Do you have a step-by-step process implemented for that? And the second is, how do you convey the message to the patients that you just described that it's a safe procedure?
Yeah. So I run a hypertension clinic where I get referred all sorts of hypertensions, and device therapy is just a small part of it. So ruling out secondary causes of hypertension is very important. It is said that somewhere between 5 and 25% of patients with hypertension have primary aldosteronism, which is an extraordinary number. I'm surprised by how high that is, but we have data that between 5 and 10% on cross-sectional studies may have this condition. Now, that is not thought to respond to RDN, although we've never tried it because a lot of them were ruled out of the studies. But we shouldn't be denervating those. So how do you do that? You get patients who are on standard meds, try and avoid beta blockers and spironolactone when you test for this. You can test on the usual meds other than those 2 drug classes, and you can get a good idea as to whether they have it with an aldosterone and a renin activity level. If they then have an abnormality, then send them to a specialist to try and rule that out. Sleep apnea, you can denervate on sleep apnea, and about 12% of the trial patients had it. And in fact, it's maybe a good indication because sleep apnea is a sympathetic nervous system driven accelerated condition. And we've seen potentially bigger falls in those patients in blood pressure. And then the weird and the wonderful stuff, the Cushing's and the pheochromocytomas, they're incredibly rare. The guidelines say do a 24-hour urine collection to look for cortisol and metanephrines and rule it out, but it's hardly ever positive in a hypertension clinic. One important thing is fibromuscular dysplasia in the young and in the older renal artery stenosis from atherosclerosis. So a duplex ultrasound will rule out in about 70%, and then you can consider CT and MRA, although that's not necessary before taking them to the lab. After that, you try and get them on combination medicines in case the number of pills is putting them off. You try and eliminate side effects. You use a trial of spironolactone, which can have a very big effect in a small proportion of people and a good effect in a moderate proportion of people, but it's not tolerated very well. Half of patients will come off spironolactone within a year because of the side effects, particularly men. So I think it's a good drug to try because in some patients it can have a very large effect, 20, 30, 40 points, and patients need to know that they can be controlled with that drug, and then they can decide whether they want it. After that, those patients come out of that pathway, and then you're looking at whether or not to denervate them. And I think that's a good pathway to go through. And historically, that's taken years, but it doesn't have to. You can do that pathway in 3 to 6 months, and that's what we should be doing. We should be doing that pathway in 3 to 6 months. But at the moment, the systems aren't geared to it. In terms of the volumes, it's in terms of uncontrolled hypertension, it is around half the hypertension population, which is around 1/3 of the over 65s. So that's a lot of patients, millions. But in reality, we want to be focusing on the very high cardiovascular risk and in those who are uncontrolled on at least 3 medicines. And that will filter it down a bit. And then over time, you rule out some from because they have secondary drivers of hypertension, some who respond to lifestyle interventions, which I haven't mentioned, but they're very important: weight loss, exercise, salt reduction. And then you end up with a manageable group. And in fact, although we were scared the volumes are going to overwhelm us, in reality, that screening pathway has been the pinch point. We can't get people through the hypertension clinics in the volumes needed to overwhelm the cath labs because the hypertension clinics are overrun already and they haven't got the capacity to rapidly filter these patients. So over time, it will scale up, but right now the numbers are manageable.
Okay, so that was, I think, quite a nice explanation of how to go through all these steps in 3 to 6 months. I think that's a good goal. Let's see if that's going to be achieved, of course, across the world. Finally, I would like to ask you about how much we have learned over years with regards to the pathology and the pathophysiology of renal innervation, so of renal nerves, and how does this impact the existing technologies? Can you describe to us which technologies we have at the moment, and what is the knowledge that we have taken in recent years that can help us guide the procedure and achieve better effects?
Yeah, so we began with the Medtronic catheter, which was a single point radiofrequency catheter, and we had to draw north, south, east, west in both arteries. And in Simplicity HDN3, it was an average of around 11 denervation burns to try and ablate the renal sympathetic nerves, which sit in the fat that surrounds the adventitia of the arteries, the renal arteries. At the time, we were told to focus on the proximal renal artery and avoid going beyond any bifurcations, and we couldn't really deliver into the branches with that catheter. When HDN3 failed, there was a reevaluation of the anatomy of the renal arteries, and what we found is that proximal renal arteries, the nerves are sometimes really quite far away, and they were too far away for that catheter. Whereas as we go beyond the bifurcation, really around the bifurcation, we find that the nerves are tightly wrapped, very close to the vessel. And so radiofrequency techniques now focus around the bifurcation. They deliver, in the trials, we delivered 44 denervations instead of 11. And so we were able to more consistently denervate patients in the trials, and that's why they were positive. For the ultrasound technology, that penetrates deeper. So it doesn't denervate the NEOM field because of a cooling liquid that circulates through the balloon, but it goes deeper. So that delivers 3 energy deliveries with ultrasound in the proximal, mid, and distal main renal artery, but doesn't go into the branches, whereas the radiofrequency goes the main and the branches, because they're different calibrations of depth and energy penetration and calibration. So they've both been shown to work in randomized trials. They both makes sense that both are delivering different techniques. We've seen work put out by Felix Mahfoud in neurointervention in 2023, where he describes the nerve patterns. And we've got this more spread position of nerves proximally, but really tightly wrapped distally. So this makes sense. Deep penetration techniques like ultrasound denervation for proximal, and then more distal denervations for radiofrequency, which is calibrated to a slightly less depth distally. And one more thing, in terms of the durability of this technique, we've got human data out to 10 years. And I did some preclinical work where we showed it in an animal model that there doesn't seem to be a signal of functional nerve regrowth out at 180 days. So it looks like if we can get this at the procedure, the initial procedure, if we get the nerves, it looks like we've got them for good.
So thinking about future, I don't know if that's possible, but understanding the renal nerve distribution, how it is in the proximal segment of the renal artery, a bit more scattered around the renal artery and also distant, and then past the branches, very close to the renal artery. Understanding all this, would it be possible to monitor this peri-procedurally so that we know to which extent we did damage to the renal nerves so that we can calculate the perceived or the expected effect on the blood pressure. Do you think that it's something in the future like that could substantiate?
It's a great question. So many people are working on this, and some devices have tried and failed. There is a new technique coming that may have solved this problem of establishing whether one has denervated successfully at the time. The only caveat about this is that if we stun the nerves, then they will stop conducting, but they may have the ability to recover. So we have to fully ablate the nerves. We have to liquefy the fat and destroy the Schwann cells and the nerve axons completely at the original procedure in order for it to endure. So it is still possible that we could do a test of any kind, find that there's no conduction of nerve traffic, and yet a small proportion of those axons could recover. So how likely is that? It seems like it's unlikely. So although there's a non-responder rate in renal denervation of around 1 in 4, I'm not convinced that that's due to procedural failure, because in animal models, we're seeing that there's a very, very large reduction in neurotransmitter release, norepinephrine, which is the neurotransmitter of the sympathetic nervous system, down by 90-95% with the modern techniques. It was less so, 60-70% with the early technology and early techniques. Now we're down at 90-95%. So I think we've probably now got the technique right. And yes, you can have these things called heat sinks, where 1 or 2 energy deliveries are absorbed by lymph nodes or the renal vein. The energy is dissipated, so you don't ablate the nerves properly in that region. But we're trying to get them at multiple points in the artery. And that's why we deliver these multiple denervations. So I think probably that the advent of that technology, which everyone asks for, can we demonstrate it like the AF ablation doctors do? I think it will come, but I'm not so sure its positive predictive value will be 100%. I think it will say that we've got all the nerves in some people, and then a few of them will come back, but I'm not so sure that's clinically important. I think what's happening is in the non-responders, it's potentially the other systems that control blood pressure upregulate, and so the blood pressure doesn't come down. But we're still working on this. We're not absolutely certain.
Thank you very much. So the final question, is renal denervation here to stay?
Yeah, I think so. There's some competitors coming up on the rails, the small interfering RNA inhibitors, where you give a single drug that can last for 6 months. That's got promise. But I think a single procedure under local anesthetic, 45 minutes, the patient goes home the same day, and they've got probably 10 years of blood pressure lowering effect if they respond. If you take the more severe patients, you're getting 15 millimeters of mercury, which is a very big effect. You'd expect that to reduce the risk of stroke by 1/3, heart failure by 1/3, from a single 45-minute procedure. I think that's quite a compelling offer for those who aren't responding to lifestyle and medicines, and there's a lot of them out there. Hypertension is causing strokes, heart attacks, heart failure all over the world. We need new treatments. I think this is a good treatment.
Thank you very much, especially given the good safety profile that you described. So that's a good argument.
Very few side effects, short, medium, or long term, as long as the procedural, it's the groin management. If you manage the groin like a TAVI operator does, then this is an extremely safe procedure.
Thank you very much, Professor Sharp. It really was, I really enjoyed listening to you, and I hope that our audience also did. This was a great description of a technology and a procedure that can help many, many patients with hypertension. Stay with us for the next episodes of Heart-to-Heart Conversations. Thank you very much.
Thanks, Dan.
Thank you.